Hi, everyone, and welcome to the Otolaryngologic Clinics Podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the June 2023 issue dedicated to vestibular schwannoma, guest edited by Drs. Erika Woodson and Matthew Carlson. Here now is our consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hi, everyone. I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. Today, I'm speaking with the guest editors of the June 2023 issue of Clinics, which is on vestibular schwannoma, Drs. Erika Woodson and Matthew Carlson. Dr. Erika Woodson is Associate Physician, Head and Neck Surgery, Kaiser Permanente, Southern California in San Diego, California. Dr. Matthew L. Carlson is Professor of Otolaryngology and Neurologic Surgery, Division Chair of Otology and Neurotology in the Department of Otolaryngology at the Mayo Clinic in Rochester, Minnesota. Welcome, Erika and Matt.
Thanks for having us.
So you have put together a terrific issue of Clinics that truly covers vestibular schwannoma, which is the tumor formerly known as acoustic neuroma, from soup to nuts. The 18 articles you've included discuss biology, natural history, epidemiology, sporadic vestibular schwannoma versus NF2, and various, which is neurofibromatosis 2, and various treatment options. Sometimes on these Clinics podcasts, we go over the articles one by one, but today we're going to do more of a big picture look. I will remind our listeners that you can access this and all issues of Otolaryngologic Clinics of North America, hopefully at their institutional or personal libraries and online at www.oto.theclinics.com. You can listen to all of the podcasts. There's one per issue since 2017 at that same website or wherever you get your podcasts. Okay, so let's dive in. Erika, Dr. Woodson, how do these tumors usually present?
They usually present with unilateral hearing symptoms, typically hearing loss or tinnitus. The hearing loss could be gradual over time, or it could be a sudden hearing loss that brings the patient in. That's the most common scenario. However, occasionally tumors can show up with really advanced symptoms of nerve compression, like facial numbness from trigeminal compression, without causing any hearing loss at all. And anytime there's a symptom which seems unilateral in nature, I recommend MRI scanning.
One of the things that we do talk about is the drop in word discrimination, which is sort of out of proportion to the pure tones. So I wonder if you can highlight that a little bit.
Correct. So the classic thing that we learn is that we can have a drop in word recognition score compared to the pure tone averages in patients who have retrocochlear pathology. Now, we don't always see that, but certainly if you see somebody who has, a mild or just a moderate high frequency loss and their word rec is really asymmetric or really severely bad, like 40%, something like that, that is a person who should be further evaluated.
Thank you. So I think unilateral symptoms, anything that doesn't quite smell right, it's very reasonable to do a workup, as you're saying. So, now we're finding these tumors, right? So when I was doing my training, we operate on everybody, no matter what the size, no matter what. Everyone got surgery for these tumors. I think we've changed and we've gone from sort of the universal operating situation to a much more methodical approach with discussions on care, including wait and scan, radiation, and surgery. And I think this is based on a better understanding of natural history and tumor biology, and frankly, knowing that we can pick up these tumors very, very early now because our imaging capabilities are so much better. So, Matt, Dr. Carlson, what's the natural history for retaining serviceable hearing in these tumors that are watched so that they're weighted and scanned every so often?
Just as you said, historically, any tumor that was diagnosed was actually would have recommended for treatment, and that was primarily a microsurgical resection, at least historically. And that was primarily driven by the fact that most tumors were diagnosed at a larger size, and there was no information about the natural history. And early on, they were treated almost like cancers, like the whole tumor's coming out with or without the facial nerve, depending on what's needed to have it removed. And over time, primarily just with the advent of CT and more recently MRI, MRI really came on the scene in mid-90s with contrast enhancement, and that really changed the scene of a lot of skull-based pathologies where you could see them, diagnose them earlier, detect them earlier, and then you could follow them over time. And it became apparent to everybody that these didn't behave like cancers, and a lot of them didn't grow for at least a period of time. And understanding that really allowed us to have a paradigm change with how we considered managing a lot of these patients. So the fact that we learned more about the natural history and because many of them are diagnosed at a smaller size early on, it opened up the doors for different treatment strategies. And in particular, I'll just speak briefly about the wait and scan approach, the watchful waiting, the conservative treatment. There's a lot of different names for it, but it's the idea that at initial detection, the patient, informed process of shared decision-making, informed consent, the patient elects to initially observe their tumor and reserve treatment, most typically for detection of growth. The old literature that we'd see in really the most widely read and cited literature for the natural history comes from the Danish group that has a basically captive population where almost everybody in Denmark that has a tumor is cared through a centralized location in Copenhagen. They have great natural history data dating back pre-1980. So they have really, really good data from that. And a lot of that was from CTs, and their definitions are a little bit different than what we use. But long and the short of it is their data, their original data, would say that only 10 to 15% of IEC tumors would grow, and a little over 20% of CPA tumors would grow. So that basically informed the idea that, in fact, a lot of these tumors don't grow initially after detection, and you could watch them, particularly if the patient's symptoms weren't severe, they didn't have a lot of hearing loss, and you could prolong the period of time that they could preserve some of their neurological function. Treatment with a vestibular schwannoma rarely makes symptoms better. Your goal with treatment in most situations is to preserve to whatever extent you can their existing neurological function. There are exceptions to that. They're probably beyond the scope of, just chatting now. But with wait and scan, the old data would say, 10 to 20% would grow. Newer data, and particularly with volumes, it's more sensitive. And a lot of the data would say now that 50, 60, or 70% of tumors will grow within the first 5 years following detection. That's interesting because now we're saying most of them grow. But I think the next step is to realize that even if you have initial period of growth, they might not demonstrate sustained growth. So you can, if their tumor demonstrates initial growth, you could actually, if it's not a lot of growth, you could probably continue to watch them so long as reliable follow-up can be certain with the patient. Define
for me what is growth.
So classic teaching is greater than 2 millimeters of growth on maximal diameter in IEC or CPA. And then with volumetrics, most people use a 20% threshold for calling something true growth, just for the noise floor of test-retest variability on I personally think it's a better approach than just looking for growth to demonstrate, to find growth, to recommend treatment. I think a better way to think about it is a size threshold, because if your tumor is 3 millimeters and it doubles in size, it's still a very small tumor. And your outcome will be, there's nobody that can tell me that a 3 millimeter tumor and a 5 millimeter tumor have a different outcome surgically. They don't. Mm-hmm. If you have 1,000 patients, they never will. And so, but if, a 2 millimeter tumor and a 2 centimeter tumor are very different in outcomes potentially. So there is some tipping point and threshold where your outcomes start to deteriorate at a faster rate. And so we studied this in a relatively large group of people, 600 people after microsurgical resection. We found the tipping point to be about 1.5 centimeters in size in the CPA, so not including IEC dimension. So we're more flexible, and this is what that paper's about in this article. We're more flexible about this idea that you don't have to treat it right when you see growth, particularly for a small tumor. But once you start getting up around a centimeter and a half in the angle, your outcomes are going to deteriorate. And so at that's probably the point to consider it. And most importantly, we're not recommending just watching everybody to 1.5 centimeters. It's just one more factor in the greater context of the patient to basically match their goals and priorities with the best possible outcome you can give them through informed consent.
That's a very judicious way of looking at these. We had started this little portion of the podcast talking about what happens to hearing, because a lot of the times patients come in, oh my goodness, I have a tumor on my nerve of hearing and balance, and if you remove it, my hearing will get better. And as you said, we are very fortunate when we can preserve the neural function that they have. And I think the techniques have gotten better and better. And so I know in the article by Brooks and Vivas, they talk about if there is serviceable hearing at the beginning of the wait and scan or the observation arm, 60% and 40% of those patients retain serviceable hearing after 5 and 10 years. And that means they continue to be observed. So clearly there's not adequate growth to force an intervention. So I think what you're talking about is the difference between a tiny tumor, a medium tumor, a large tumor, what growth actually means and where it makes a difference. And I think that 1.5 centimeters in the CPA does really make a difference. Do you also, maybe Erika, I'll ask you to chime in. Do you feel differently if the tumor in the canal, in the internal auditory canal, is more laterally biased or more medially biased towards the brainstem? It's like, 5-6 centimeters more lateral or maybe 1.5 centimeters, but really jammed up in that lateral porous versus extending into the cerebellopontine angle?
I think for me, it matters as far as thinking about the prospects of hearing preservation with intervention. Specifically, if the tumor is really, really close to medullus, I don't care how you plan the radiation treatment. The cochlea, the medullus, is going to get a kill dose of radiation. Likewise, if the tumor is really impacted in the fundus, I think it does affect how we're able to get that tumor out and save hearing if we're doing, say, like a middle fossa for hearing preservation. Because all those approaches that are hearing approaches, and we'll talk about that a little bit more in this segment, they're all going to leave a little bit of a blind spot if it's an inferiorly based tumor that you're just kind of feeling around for there. So anytime it's really impacted laterally, you're hoping you get it all, but it's harder to do so with direct visualization with those hearing preservation approaches.
So I think we've talked about various approaches that are used to help patients and their families through this decision-making for sporadic vestibular schwannoma. And I'll draw our listeners' attention to the article by Choi, Ventaker, and Adams. They have some really nice figures in there for shared decision-making in this particular entity. What do you talk to patients about regarding their quality of life once they receive this diagnosis, Dr. Carlson?
Historically, the benchmarks for treatment outcome were always tumor control, facial nerve outcome, and potentially hearing preservation if the tumor's small enough and the hearing's good enough to begin with. And over time, there's been a number of patients that I've treated and other people have treated and observed a similar thing, that even if you win at those things, they're not always happy. Sometimes they have dizziness, sometimes they have headaches, sometimes they have bad tinnitus. And a lot of these other things are items that are difficult control, and they affect their outlook on life significantly, maybe even more to that person than a facial paralysis or something like that. So the idea of studying quality of life came from the observation that what we prioritize as physicians is often disparate from what a patient appreciates to be more important. And so quality of life just looks at the patient's global overall appreciation for their outlook on life and how their journey through the treatment is for them. And for a tumor that is benign, that is generally slow growing, and for a tumor that, nobody dies from a vestibular schwannoma these days, or very, very, very rarely in the United States you would. And so just to say, other things have to come to the surface. So quality of life is one of those metrics that is increasingly used in all of medicine. And fortunately, it's also come through in vestibular schwannoma too to help guide treatment. Historically, there wasn't a disease-specific quality of life measure for vestibular schwannoma. People use generic measures like the SF-36 or the PROMIS or the Glasgow Benefit Inventory, things like that. And then in 2010, the PANQUAL that was developed by Penn, and that was the first disease-specific measure, which was really valuable. And more recently, we've studied that, and we've looked at a large number of patients using the PANQUAL, and through patient input and some of our different studies, we've created a new quality of life index called the VisQual, the Vestibular Schwannoma Quality of Life Index. There's a couple things that are worth saying. The first thing is it's very valuable to include quality of life outcomes and not just facial nerve outcomes, tumor control, and hearing preservation, because that's the patient's overall outlook. The second thing is, as providers, we believe that we have probably more power than we really do. A patient, they present with symptoms and priorities and conditions. And as long as you do a good job, as long as you're doing a good microsurgical resection or doing a good dose plan with your radiosurgery or being thoughtful in your observation, basically the outcomes between the different modalities are actually pretty small from a quality of life inventory, even if you use the disease-specific measures. Like, for example, we looked at 300 patients at longer-term follow-up, a minimum, I think, of 3 or 4 years follow-up. The mean change on the whole population was like 1 point on a 100-point scale after treatment. And so the patient's baseline is the biggest predictor of how they're going to do with quality of life long-term. We still want to provide good care the best we can, but it's difficult to modify quality of life significantly. The goal is to maintain it the best you can. There are some interesting side discussion points. One area that we do tend to modify quality of life is there's a subset of patients that are distraught over the idea of having a brain tumor, even after we counsel them that it's benign and even small and slow growing. They can't stop thinking about it. They lose sleep about it, and they just have a lot of anxiety about it. And it's not unreasonable that can occur. I can understand how that can occur. But so a subset of patients, for example, get a significant anxiety and mental health quality of life improvement after surgical resection, for example.
I think what you're saying is, yes, we can talk about the subject of vestibular schwannoma, but when you're confronted with a patient and their family, it's really takes a lot into consideration about where they've come from, what kind of stuff they've read, or people they've met in the grocery store who also had this, and whatever. And really, that if it's eating away at them with anxiety because there's this tumor and you cannot figure out a way to convince them that it's not, because I think we all have that conversation. It's not cancer. It's only, let's say, 1.5 centimeters. It's not pushing your brainstem on the other side, so on and so forth. I think there are very justifiable reasons for intervention that are bigger than the size of the tumor. I think, Erika, we had talked about radiation. Can you talk about, and we're talking about sporadic vestibular schwannoma. We're talking about tumors that would be amenable to radiation, so there's a particular size limitation. But can you tell us some details that we as surgeons should know about radiation for these tumors?
Thank you for allowing me to sort of bring this up specifically. When I was in training, I think that radiation was a 4-letter word, and it wasn't a very nice word. And I think a lot of microsurgeons still have a very strong bias against radiosurgery. Radiation as an option. However, if you really break down the literature and look at the comparisons between radiation and microsurgery, and of course the observation arm, there's no question, based on, the data that Matt's presented, there's no question that the quality of life is similar. There's no question that the control rates are not perfect, but pretty good. And doing radiation for tumors of a certain size, in many hands, will lead to a better, maybe facial nerve outcome than doing microsurgery. So, I do believe that as surgeons, it's really important that we not be hammerologists looking for those nails, that we be able to speak to both of those arms of treatment to, again, be able to present the options, in a way that the patient will be able to understand and they'll choose. How I like to present it to the patient is that there is no, frequently, well, let's say, in many cases, there is no right answer. There is not one option that really is elevated over the rest of them. Radiation, I like to say, you're kind of paying for things on the layaway plan. You may not experience any symptoms up front. You may not have a big recovery like you would for surgery. However, the things that can happen with surgery can still happen over time after radiation. Like, you're likely to have further hearing loss. That's very, very likely after radiation. It may not happen tomorrow, but it's going to happen over time. You may experience dizziness or imbalance. You may have symptoms of facial spasm or facial numbness, all those things that can occur after radiation. And of course, this is what happens if it fails. This is what may happen if you fail radiation. This is what that can potentially look like. It's really important that people understand the short and the long-term implications of their choice.
Thank you. I agree with that. I think, there is a limitation. So what is the upper limit of size that you would recommend radiation? And do you wait for tumors to grow before you suggest radiation for the most part?
For the most part, I do recommend observation before radiation, unless, of course, it's a big size, because then I get concerned that we're up against the possibility or likelihood of worse outcomes from compression if that tumor were to grow. And how I explain it to patients is, immediately after treatment for about the first year, we're going to see some swelling related to that tumor treatment. And if it's already pretty big, you have to have room for it to swell, or you're going to get other symptoms. And so classically, the cutoff for considering radius surgery was about 2.5 centimeters, considering for radius surgery. But there has been some recent introductions in the literature of tumors. This is a multidisciplinary group that published a couple papers on it, very large tumors, like 3+ centimeters. Now, I don't know what went into the decision-making for radiation for those individuals, but I feel like a lot of them were probably, just refused to have surgery of any type, or perhaps were too ill to consider microsurgery. And the bottom line is these patients did better than we would have thought they would, but they did have issues with compressive symptoms. So they were more likely to have hydrocephalus. They needed a shunt after surgery, say like about 10%. And they did have a higher incidence of trigeminal neuropathy and trigeminal nerve pain. So either pain or a numbness in the area. And again, some of them failed, but they didn't fail really in higher numbers than we would expect for the other sporadic tumors. It's just that we were likely going to need to control or mitigate other compressive symptoms, likely because of that swelling that occurs in the subacute timeframe after the treatment.
And, I think one of the advances that has happened over the decades is that, yes, radiation was considered a 4-letter word by us microsurgeons. But what has happened is we have embraced our colleagues and learned from each other in order to provide care and actually correct follow-up to see what does happen with these various treatment modalities. So speaking of being surgeons, you've included separate detailed articles on various surgical approaches, with each one containing information on patient selection, on technical pearls, and on patient outcomes. The images and the details in each article are outstanding. I think our listeners very much appreciate those details. You also included an article on identifying and managing surgical complications, which I think goes part and parcel with approaching these tumors. So, Matt, give us one pearl for each surgical approach: translabyrinthine, middle fossa, and retrosigmoid. And again, we are talking about small, medium, and sort of large tumors, and we're really not talking about the huge tumors that pose a different set of problems.
If it's okay, I'm going to actually just give some central tenets that I think help with all of them. A lot of times people like to talk about how the translab is so different than the retrosig, and the retrosig is so different than the middle fossa. The translab and the retrosig are a very similar corridor. One is just a centimeter in front of the sigmoid. It's right in front of the sigmoid, and then one's just right behind the sigmoid. So a lot of the, I don't know, I always have a hard time with these sorts of questions because a lot of the principles apply across the different surgical approaches, but just some very important tenets that will help you with your surgical resection, regardless of which of these three approaches you're talking about. The first thing is to get more exposure than you think you're going to need, because sometimes things come up in a case that you don't anticipate, and just having a good illumination and good space for your both hands is very, very valuable. The second is wide decompression of your troughs, your IC. That's not just, so a lot of people think, well, that's just really good for your hearing preservation cases, so you can roll the tumor around and without, creating a lot of traction on the nerves and things. It's more important on a very large tumor. So especially on a translab approach, if you have a very large tumor or something even over 2 centimeters on a translab approach, if it has, more extension anterior to the IC, you really need to drill deep troughs in the petrous apex, so you're seeing that anterior edge of the tumor. So don't skimp on your troughs. If you read books, they'll say, at least 270. And I think that's true. And I'll cheat sometimes if trying to get through a case and you're moving along, and sometimes you'll do 180 and or whatever, and you'll say, oh, I wish I would have drilled more. So don't cheat on the troughs. Spend the time to do it well. Then the next thing is, even for small tumors, debulk the center core of it before you start working on the capsule. It gives you a lot more room. All the tumors we work on, you're in a tight, confined space. And even if you get good exposure, and even a medium-sized tumor can feel tight sometimes. So take time to get exposure. Take time to let CSF off and let the brain relax. Centrally debulk a lot before you start working on the tumor capsule. It just relaxes your space and allows you to work more easily. On bigger tumors, I'm much more meticulous with hemostasis throughout the case, because you just don't want your field to fill with blood. On a really small tumor that I'm trying to save hearing on, I'm actually very sparing on bipolar. So I only use it when I really need to. And there's a saying, once the tumor's out, the bleeding will stop too. And that's okay on a really small hearing preservation case, I think. So different, you're kind of approaching it differently from those two. Look at the patient in the greater context. If they're an 80-year-old patient and they had to have brainstem decompression because they have a 3.5 centimeter, 4 centimeter tumor, you're going to treat that differently than the person who's, 30 years old and has a medium-sized tumor. The difference being that in the older person, the main goal might be very good brainstem and cerebellar decompression, and you're more willing to do a subtotal resection. In a younger patient, in general, your preference is for more aggressive resection. Work in a team, it's not just having good hands, but it's a lot of judgment. And so having a neurosurgeon and a neurotologist working together, not only do you give each other breaks, and each person has their own expertise for different parts of the case. A lot of teams are interchangeable. A lot of the case, especially after you've been working together for a long time. But there's a lot of times where there's just you're tired and you have to think about it the right way. Like, should I take out more? Should we work somewhere else? The nerve is starting to deteriorate. We're getting a drop in our min stim or our supermax stim or whatever. What does that mean? Should we work somewhere else? Or should we stop? Those sorts of discussions. And then also think about your discussions with the patient ahead of time. Some patients just will not tolerate a facial paralysis, and some are more about getting the whole tumor out. And so you approach every single decision with the patient's wishes, goals, and priorities in mind, even when you're operating too. Those would be probably some general tenets or concepts that probably allow you to do well with all of the different approaches.
So I asked for a couple of pearls and you handed over a pearl necklace. And really beautifully said. I completely agree with you. I think that the two sets of eyes and the two brains and the two sets of hands, when you're working alongside a neurosurgeon who really has that team approach, it really 2 + 2 is much greater than 4 in those circumstances. I think the patient really benefits from the camaraderie and from the willingness of each of you to sort of talk it through as you're dissecting or as you're watching. Erika, anything extra to add about this?
Yeah, just thinking about technical pearls, I definitely pay more attention to the surgical corridor. And I think I did during fellowship, where we took a more singular approach to tumors. So definitely, if somebody has a high jugular bulb, or they're getting very little drainage out of the other side, I'm going to be more receptive to a retrosigmoid than a translab, just because we now appreciate that the extent of thrombus or low or no flow out of the sigmoid is actually pretty high after the translab approach, whether or not that's, just compressing it with the fat or whatever. But I'd really like to make sure that my patient can tolerate little to no flow out of that opposite sigmoid, because I know I can get there with a retrosigmoid, and I don't feel necessarily compelled to, put them at risk for that. And when I think about some of my more miserable patients, I think about the ones that had acute intracranial hypertension because we had a sluggish flow or a thrombus in their better drainage side.
That's really interesting. Thank you. I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. I'm speaking with Dr. Erika Woodson and Dr. Matthew Carlson. Dr. Woodson is practicing at Kaiser Permanente in San Diego, California. Dr. Carlson is practicing at the Mayo Clinic in Rochester, Minnesota. They are the guest editors of the June 2023 issue of Otolaryngologic Clinics of North America, which is on vestibular schwannoma. You can get all the issues and articles and podcasts at www.oto.theclinics.com or wherever you get your podcasts. So let's get back to the discussion. I said before that you also included an article on identifying and managing surgical complications. And then you included an article on managing tumors that failed the initial treatment. So operating on a tumor that has had nothing done to it or radiating a tumor that has had nothing done to it is one set of issues. But intervening on a tumor that has previously been radiated or operated on is quite another. So, Dr. Woodson, can you give us some idea of how you approach surgical failures and radiation or radiosurgery failures? And how do you counsel and what kind of approaches might you use?
Okay, so in a single word, the answer is slowly. Very, very, very slowly. Thinking about the radiation aspect first. First of all, if somebody has had stereotactic radiation, there is a period of time which is called pseudoprogression, the point at which, yes, it's a little puffy, it's a little swollen, it's a reaction to the treatment, it's not actually cellular proliferation. In other words, the radiation does take a little bit of time to catch up to the tumor. So classically, we thought about pseudoprogression window as being about 3 years, but there's actually some literature that's come out that suggests maybe it's more like 4 years. Maybe we should give it another year, as long as the patient's not having really concerning compressive symptoms or something that clearly looks like egregious growth. So, if we think the tumor is growing after radiation, I try just to tread really slowly on it, hoping that eventually, again, the radiation will catch up and we don't have to put that patient through a salvage surgery. The article by Kay Rivas and Roland, I thought was really nice summary of all the different aspects: surgery to radiation, radiation to surgery, surgery, radiation to radiation. There's actually a really nice table in it that talks about some of the side effects or complications that we can see when we go from one treatment to the next. And so, things that were pretty insightful to me with that is that, yes, in general, it all seems to work. The facial nerve outcomes are not quite as good with salvage surgery, either after prior surgery or after radiation, but it's not terrible. And we think, if we're going to operate after radiation, the facial nerve is going to be toast, but really it's not. And, very careful patient counseling is going to be important so they understand that facial weakness is a potential. Another thing that's really impactful from this article is that, in my brain, I still think, if radiation didn't work the first time, why would I do it a second time? But there are actually some articles where they treat radiation as salvage for radiation. And it actually does seem to be beneficial for those few patients that underwent that. So I think in general, if you do surgery and if it's subtotal and you're watching the tumor, in general, you want to give it a lot of time to really sort of declare itself. Sometimes you left a little chunk behind and man, you just can't see it on an MRI scan. So it may take 3 or 4 years before regrowth may be apparent. If something looks nodular early, it's likely going to be impactful later. But sometimes really small pieces of capsule just turn into scar and don't amount to anything over time. So again, approaching that sort of carefully, not being quick to judge recurrence or residual tumor, I think will be helpful in the long run.
Fantastic. So we've been talking about sporadic vestibular schwannoma, but let's pivot over to neurofibromatosis 2 or NF2. So assessment, counseling, and management of patients with NF2 is pretty complicated. The tumors are aggressive. They don't really peel well off of the surrounding nerves. And these patients often face a number of communication and quality of life challenges. Dr. Carlson, there are a number of agents that are being used in various clinical trials for NF2, primarily to reduce tumor growth and maybe to give some shrinkage. So can you give us a quick update of these and what you see as the most promising?
Yeah, if it's okay, I just want to give a real brief. We always think of neurofibromatosis type 2 and sporadic tumors to be very different tumors. Early on, the saying would be that they're more difficult to separate from the nerve. They have a higher growth rate. They respond less to radiosurgery and all these sorts of things. And I think there's some recent data that really tells me that a single tumor in an NF2 patient behaves no differently than a sporadic patient's single tumor. The only difference is you have clusters, you have polyclonal populations of tumors that are by each other, and the nerve can weave in between those tumors, and it creates a worse outcome in the NF2 patient. But there's some really good data from the Manchester group that looks at the microenvironment of individual tumors, and they actually look very similar. We did a study that looked at, we did next generation sequencing or deep sequencing, and we actually found 100% of patients had a double hit in the NF2 gene in sporadic tumors, just like the NF2 patients. So I actually think that if you took a single tumor from somebody in NF2 and you had, the single tumor that defines what a person has with a sporadic tumor, you only have one, they actually look very similar. The problem is you just have many more in NF2 and they can affect many different nerves. And so it creates all this additional morbidity from it. So having said that, I think that a lot of the treatments that are being used and trialed in the NF2 population eventually in some ways might make their way into the sporadic population for people who have a more severe or resistant tumor. The problem is a lot of these treatments are costly and they have significant side effects, risks like renal risks or hypertension or all these sorts of things. And so it's hard to justify for a benign sporadic tumor giving somebody systemic therapy over months and months with all these side effects. You have to have a pretty bad tumor or disease to justify some of these treatments. But I just want to say that what we're learning in NF2 is going to apply to patients with sporadic tumors, I think, because I think the tumors are actually pretty similar. So it gives us a lot of information. I think a lot of it can transfer over. Ideally, I think in 100, so if you look back 100 years from what people did for vestibular schwannomas, there was a very high mortality rate. 80% of people would die from having their tumor resection. And now almost nobody dies from a vestibular schwannoma, at least in the United States and other developed countries. And so we'd say what they did before was pretty crazy and not very good. And in 100 years, they're going to look back at what we're doing now and say, we were crazy. I can't believe they were taking them out. All we did was we gave them this pill and their tumor stopped. And now they didn't have any of this morbidity, or maybe they use some other treatment we can't even conceive of now. But just to say, I think increasingly some of these medical treatments are going to find their way into the armamentarium of us to provide better care for our patients. So having said all of that, when you look at vestibular schwannomas under the microscope, there's a high density of macrophages, which is really strange. Like up to 50 or 60% of the wet weight of a tumor is actually comprised of inflammatory cells. It's not like all neoplastic cells, which is really super interesting. And so a lot of these anti-inflammatory medications may show promise in treating some of these patients. There's a lot of this, are they implicated in the disease or are they an innocent bystander? And a lot of this has to get worked out. But there is a lot of inflammation that actually occurs in these tumors. And so it'll be interesting to see how some of these medications work. But broadly, the most common medications that have been tested in the NF2 population are the VEGF inhibitors. So bevacizumab is the most common one. And typically that's used for patients who have global progressive disease, a lot of tumors growing, or they have focal disease that is also refractory to standard surgical and radiosurgical failures, or for hearing preservation for a period of time. If you try to develop an algorithm for management of NF2, it's just too hard. Every patient is so incredibly different with tumors in many different locations and many different symptoms and different priorities. And so I think it's hard to really create a good algorithm when you're going to use one of these. It's very individual specific. And I always say you have a plan until you go into the room and you talk to the patient. You have an idea what you're going to do, and then you go in there and you talk to the patient, and you might change completely you might even walk out saying, don't think I'd ever do that again, but they really value this outcome or whatever, and you chase that for them sometimes. But VEGF inhibitors, bench research that shows that aspirin has the ability to slow the growth of vestibular schwannomas. I would say that, in my opinion, the clinical data in humans with sporadic vestibular schwannomas is, I would say, equivocal right now. There's not overwhelming evidence that it is providing tumor control. There's conflicting data out there right now.
Yeah, I think many researchers are urging a slow roll on that aspirin because we may be trading a non-effect for increased danger of, other complications of taking aspirin when one doesn't need to. So I think, we all have experience of people coming in and saying, I got this article from, the interweb and, I'm going to start taking aspirin. And I'm like, I don't think there's any data yet for that. I think this is the area, we had talked about this when you both were putting the issue together about, where to highlight. And when you're looking at what the crystal ball needs to show us. I think this is one of the things that the crystal ball needs to help us with as we go into the future. There's an article that you included talking about cochlear implants and hearing restoration in patients, particularly with NF2-related vestibular schwannomas, and it's by the group in England. The group led by Emma Stapleton state that the priorities of vestibular schwannoma treatment are, in order of importance, to preserve life, to preserve facial function, and to preserve hearing, and to minimize complications. So, Erika, can you tell us a bit about how cochlear implants are fitting into the picture for patients with either sporadic or NF2-related vestibular schwannomas?
Yes, find more reasons to put cochlear implants in patients. So no, but in all seriousness, auditory brainstem implants have frustrated people for a lot of reasons for a long time. They require an incredible amount of expertise, not just on the surgeon side, but on the audiologist side as well, to try to place them, to program them, to work them. And overall, the results haven't been too promising. For individuals in whom we can save a functionally and structurally intact cochlear nerve, we are starting to do some cochlear implants and seeing relatively good results, better than auditory brainstem implants. When I looked at their article, I was actually surprised when they pulled all the data about how good some of these results seem to be. My institution's experience has not been that superlative. But, in general, people can get the sound awareness, they can have some auditory abilities, they may help with lip reading all the way up to open set. And a lot of patients who, have a cochlear implant may be able to achieve some open set, whereas it's a really rare accomplishment for patients with ABI. Additionally, a cochlear implant is something that, pretty much any skull-based surgeon can also put a cochlear implant in. So its ability as a rehab option to, expand beyond just a small handful of centers expertise in the country, I think is really important for individuals. So it is something that we consider for NF2, particularly because we're so concerned those patients are going to end up in a completely non-hearing world otherwise. But we are on occasion doing it for select patients who have singular sporadic tumors. I think the challenge here is really the insurance authorization. That's a real sticking point. And if one can't do it at the time of surgery, there's the concern or the risk that wouldn't be able to come back and do it because of cochlear ossification or fibrosis.
Yeah, I think in England, the National Health Service tends to do one or two things right. And they really have very good economic advisors that really look at essentially return on investment on medical interventions in a very particular way, very public health spirited, but economically driven way. And I think that's something that they have advocated at the NHS for unilateral and bilateral cochlear implantation because of the societal benefits of such. So Emma Stapleton, who wrote this article, is actually going to be my guest of honor at the American Otologic Society meeting in Chicago in May of 2024. Very much looking forward to the transatlantic sharing of information. So let's talk about the facial nerve. I trained in my fellowship at the House Ear Institute, and William House and Bill Hitzelberger were the neurosurgery team. And if something untoward happened to somebody's facial nerve, the punishment for this big man, neurosurgeon, Bill Hitzelberger, was that Bill House would make him go to the temporal bone lab and drill out 12 translabs to make sure that he knew how to do it before the next case. Like this was talk about a collaboration and a true respect and trust in each other. But sometimes things happen. The tumor is very large. The facial nerve is very, very splayed out and spread out. Unfortunately, in some percentage of cases, these patients have some facial nerve weakness or paralysis postoperatively. So, Dr. Carlson, what can our facial plastics colleagues offer patients when there's lasting facial paresis after treatment, whether it be radiation or surgery?
Yeah, the old historically, and still at a lot of centers, the neurologist and the neurosurgeon will manage post-operative facial paralysis, but increasingly the facial plastic surgeons are getting involved, and I think it's good. They have a lot of extra tools in the armamentarium for treatment. So I think one very important principle that's really changed in the last 5 or 10 years, or maybe a little bit longer, is just this idea that historically, if the patient developed facial paralysis, we would give them a year or 18 months or even 2 years before we do an intervention, a reinnervation procedure with, like, say, a hypoglossal or something like that, because you really wanted to be sure they're not going to recover before you'd splice their nerve and plug it in with a different nerve. There's pretty good data, and actually a paper by Rivas not too long ago with Kofi Bohinen, Johns Hopkins, that demonstrates that just this principle that time is motor end plates. So the longer you wait, the more you lose muscle. And even if you plug something in later on, if you've had some terminal atrophy, you might get past a point where you can actually have a good reinnervation outcome. Mm-hmm. And so there's good data that says right now that if you're not getting any recovery by 5 or 6 months, that doing reinnervation procedures at that time probably provides you with a better outcome. The idea being, even if you get some improvement after 6 months, if you don't have any significant improvement before that, it's still not going to be a very satisfactory outcome. So maybe you'll recover to a 4 or 5 or something, but still not very good. So the idea is intervening early for those people. It requires a good collaboration between the microsurgical team that's doing the tumor resection and also the facial plastics group. What they want to know is the nerve anatomically intact? If it is not anatomically intact, you'll try to do something at the time of the original surgery, often interposition or plug something else in. But if it is intact, you're going to see if it's going to improve or not. The facial plastic surgeons will often do other things too. So it's not just getting motor function back. A lot of times you have hypertonicity or synkinesis, and they'll do they'll do selective denervations, which is less common, but they'll selectively cut small branches at the terminal ends of the facial nerve to make more symmetry. Sometimes they will administer Botox periodically throughout the journey, and then just general non-surgical facial rehabilitation. They'll work with the patient. I think by incorporating that group, we're really improving outcomes. And I think plugging them in earlier rather than later is always good. So if we have a person that has a pretty significant facial paralysis and we're not seeing any significant improvement by 3 months, we're actually plugging them in with our facial nerve surgeons, the facial plastic surgeons early, just to make sure we provide the maximally best outcome that we can provide them with collaborative multidisciplinary care.
Yeah, I think one of the advantages of having them take care as part of a team is that it's hard to, just as a human being, acknowledge something that went wrong and try to fix it yourself in these patients. And I think that's why when you started by saying, we used to do it all ourselves, right? You used to say, okay, now we've done the tumor, now we'll do the 712. But I think having somebody whose expertise is that, who's, who cares about the patient, they're emotionally not wrapped up in the things that led to this facial palsy is actually very, very important. So we're going to wrap up as you guys did with this issue of clinics, talking about the future. You have an article in there by Moore and Stankovic, which has really beautiful figures that kind of imagine the future in a different way. So Erika, what is the future in diagnosis, prognosis, and management of vestibular schwannomas?
I love this chapter because it was kind of like, it was a moonshot chapter, right? Like the whole chapter is like, what could be coming down the pike? And, we sit around, we talk about the same surgical approaches for decades. This is the stuff that is some ways still far away in a translational sense, but just it gives me great optimism for what our field could be during the course of my career. I think for the diagnosis, prognosis, and management, I think you mentioned earlier, we're looking for that crystal ball, right? We want to know which tumors are going to be good players, which are going to be bad actors, which may be more likely to save hearing, allow hearing to persist long-term versus, which ones might be a good radiation responder versus not. Matt mentioned all these different, chemical treatments that might be on the horizon. Are there tumors that are going to be better suited for that or not? And so a lot of the diagnosis, prognosis, and management stuff, some of it's going to be in imaging. Some of it's going to be an advanced imaging that may help us predict exactly where the facial nerve is going around the tumor or something like that. But we're talking about maybe some biochemical markers, end lymph sampling, serum levels, things like that we could potentially use to help fill out that crystal ball picture of what may be happening in that tumor long term. And that's really going to influence treatment decisions if we know better what the individual behavior of the tumor is likely to be.
Very nice. And then Matt, so what's the future in treatment?
It's funny if you'd say, this is a very niche topic on a very specialized benign tumor that people would call rare before. I call them uncommon, but not rare. There's so much developments, at least from my perspective. You see new things coming out all the time, and it's super exciting just in general. So I just have to geek out for a second on that. I'm going to dovetail what Dr. Woodson said. The first thing is individualized treatment based on biomarkers or radiomics or something else like that. So you can look at an individual patient or their individual tumor and look into the future, into the crystal ball, and know it's all a chess match. So if you know what your opponent's going to do, you can preempt it, and you can give it a treatment appropriately earlier and have a better outcome if you can predict with high reliability or certainty. So biomarkers or radiomics or something else like that to determine what's going to happen. Medical therapies that have low side effect profile are going to be the holy grail. If you can just take a pill for something rather than having your head cut open with a craniotomy, that's preferable. So I'd say those are probably similar to what Erika said earlier. Those are that's the holy grail, is very individualized treatment, and then less invasive, least morbid interventions.
So I want to thank both Dr. Erika Woodson and Dr. Matt Carlson for spending this time with me today, and also for putting together this really terrific issue on vestibular schwannoma, which was the June 2023 issue of Otolaryngologic Clinics of North America. Thank you so much, Erika and Matt, for spending this time.
Thank you for joining us for this edition of the Otolaryngologic Clinics Podcast series. For an exclusive discount on the issue we discussed today, focusing on vestibular schwannoma, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics podcast wherever you get your podcasts.